All right, this is Dr. DeShavo. We are back with part 3 of chapter 12, musculoskeletal. We're into the dysfunctions, right, and diseases. So we're picking it up at fracture repair. So you have a fracture, the bones are approximated. Hopefully, these are the steps of repair that it goes through. And you can see that the ends of the bone have to be approximated. Even with that slight difference, even that little bit, it'll heal that way. So you don't want a bone to heal that way. You want it to be end to end. The first thing that'll happen is a blood clot. White blood cells and red blood cells and platelets will move in there, clotting, and start cleaning up the mess. Macrophages will move in, and right behind them, you will actually have cells which will start to deposit fibers, and those fibers will start to form the callus. There's actually a cartilaginous precursor called a callus, which then turns into the bony callus. And you get a spongy network of bones starting to fill in the damaged area, cleaning out, all the junk previously, and starting to get that bone built back to what it would originally was. You get that bony callus between those bones, and then the healed fracture. And this healed fracture will keep remodeling until it is as close as possible to the original bone. Okay, so important things to remember. Blood clot brings in white blood cells and red blood cells to fix the area and also clean the area out of infectious agents. It turns into a cartilaginous precursor to the bony callus, which will eventually remodel into the compact bone and the little bit of spongy bone on the inside. So some complications: delayed union, especially if they're not approximated, or malunion if they are not approximated, or non-union if there's poor nutrition and they don't have enough nutrition to provide vitamin C for the cartilaginous precursor, and then calcium, D, phosphorus, magnesium for the bone mineralization. The inadequate blood supply. We know that bones are very full of blood. They need that blood to regenerate. If you have a blood vessel that is cut off, you can have that bone die and necrose. So not only do we have fractures, if you cut off the blood supply to a bone, you can have that bone die. Malalignment, we spoke about. Premature weight bearing in a child that's not ready and or doesn't have sufficient nutrients to make the bone strong. Fat embolism, you have some sort of damage, you throw a fat clot that goes into the body after a fracture. You could get an infection, which would be your osteomyelitis or osteonecrosis, or avascular necrosis, which is death of that bone tissue. There is one bone I could think of, for example, off the top of my head, that is in the wrist, and that bone is your scaphoid, and there's a blood vessel that wraps around it. If you throw a punch the wrong way, you can damage that blood supply, and you can actually have necrosis of that scaphoid bone. Dislocation is a separation of two bones at a joint. So this will be two of those long bones, or a long bone generally into the shoulder or pelvic girdle, and these can separate if they undergo a large amount of stress. Could be partial, which is also known as a subluxation, or it could be more advanced or complete. Usually there's different degrees. So most common in the shoulder and the clavicle. You could get dislocations of the hip, but that's got to be a pretty intense trauma for that to happen, because your femur sits so deep into your pelvic girdle, and there's tons of ligaments that hold it in place. So treatment would be reduction. Oh, fingers are common dislocations too. So I love this. Spontaneous gentle manipulation. Actually, from what I've heard with shoulder, the more gentle you are, the easier it goes back into place. Fingers are tough. I interned with an orthopedist, and a young lady had come in. I think she was in some sort of sport, and her one of her digits, it wasn't the thumb, I think it was middle or fourth finger, was completely dislocated. It was the grossest thing. I mean, I've dissected cadavers, I've sat through surgery. I don't know, I got a thing with joints, I guess. He comes up, he goes, oh, let me see it. Bam, yanks it back into place. So gentle, I laugh at, because with fingers, it's not always so gentle. Maybe there's easier ways to do it, but when I interned with this orthopedist, I guess he was a little old school. And then that joint, after you have had a dislocation, is going to be damaged. You need to immobilize it. Generally, there's swelling that needs to go down, but you also need to go for physical therapy for weeks after you've had it reduced, because you've overstretched the ligaments around that joint. You need to strengthen the muscles around that joint, so it will help to stabilize it. It's very important for people to follow up with physical therapy of some sort with dislocations. With the shoulder, it generally dislocates anteriorly. So here's a picture of the humerus sitting into what's called the glenoid fossa of the shoulder. And you can see with this glenoid fossa, it's much more shallow than the acetabulum of the pelvic girdle. The acetabulum looks more like that with a femoral head sitting in it. So it's just a deeper indentation in the acetabulum of the bony pelvis compared to a fairly flat surface with this glenoid fossa. So we're more prone to dislocate this humerus in the shoulder joint. And the way that this dislocates is it will dislocate usually down and forward. Excuse me. And you can see here they drew this capsular ligament stretching. That's what I mean. When you have some sort of dislocation, if we compare top to bottom, the ligaments around it will stretch. And because they stretch, they generally will not shorten, because they are avascular and they only get their nutrients through osmosis, so they don't heal as quickly or repair as well. So after you have a dislocation, you've got to strengthen the muscles of the rotator cuff, excuse me, to support this joint better. So a sprain is an injury to a ligament. A strain is an injury to a tendon, just to note the difference. So we're most commonly apt to sprain the ankle and the knee because of all the ligamentous structures around those areas. There's a grading scale. You don't need to know what the grading scale is, but there's different degrees of involvement. And that varies, actually may have it on the next slide, that varies according to if it's been stretched, torn, or completely torn. Let's see if that's what's on the next one. Here we go. Yep, here's the grades. So grade 1 is a ligament is stretched. Grade 2 is a ligament is slightly torn. Grade 3 is it's torn completely. And there are several ligaments in the ankle that can get damaged. In the ankle, as a side note, we tend to invert the ankle like this because on the outside of the ankle we have fewer and thinner ligaments than we do on the inside of the ankle. So when we sprain the ankle, not to say that you can't evert it or roll it out, but we're prone to invert it that direction because of that difference in the ligaments. Here's your strain, and this will be an injury to a muscle or a tendon. Usually can stretch it or tear it. It could tear the muscle or the tendon, and it can get to the point where it pulls the tendon right off the bone. That actually is called an avulsion. You should know that. An avulsion is when tendon comes off the bone. We see this with the biceps. You can avulse your biceps where your elbow is, and it can actually roll right back up into your shoulder. So with a strain, this can occur suddenly or develop over time, and we can also get this in the low back from lifting, pushing, and pulling, which you guys do all the time. So I'm sure several of you are going, yep, I've strained. So treatment. Often I don't go over treatments, but this is such an easy treatment. I think it's important to know it. So NSAIDs are good for these strains. And rest, ice, compression, elevation. And the reason I'm going over that is because I bet you guys strain stuff all the time with the work you do. So there's your treatment. Rest. Yes, I said rest. Rest, rest, rest. Unfortunately, with strains, you have to rest. I don't think laying around all day is a good idea either. Get up, move, maybe every half an hour, just gently, and then rest again. You heal when you rest. Use ice, use compression and a wrap if you have to, and elevation to decrease the swelling in that area. So a herniated intervertebral disc is when we have, and I'm looking ahead, I have a picture of this. So there is that gel in the center I spoke to you about. It's called the nucleus pulposus. That gel can push out through the harder connective tissue fibers on the outside of a disc called the annulus fibrosus. And that exposure of that nucleus pulposus, or that gel, actually triggers an immune response. Because that nucleus pulposus is hidden in the annulus fibrosus from birth, our body doesn't recognize it as our own tissue. So when people actually herniate their disc and that gel comes out, they have an immediate severe immune response with tons of swelling. That's why these are so painful. So herniated disc can happen suddenly or gradually, and it can also expand far enough that it can put pressure on the spinal cord or the nerves that are coming out of the spinal cord. And it could be sensory, motor, autonomic function, or both, depending on the size of that herniation. It's most frequent in the lumbosacral region, but we see it throughout the whole cervical spine as well. It's really, really rare in thoracic. And I think it's because the rib cage limits the movement of the thoracic spine. It can lead to permanent neurological damage. If you have a patient that's presenting with sensory deficit in one leg compared to the other due to a herniated disc, that's not a good sign. But if they have motor, it's a really bad sign. So just as a sidebar, if you have a patient that has or is beginning motor loss, you want to get them to a neurologist or a neurosurgeon as soon as possible. So I left this in here because guess what? Are you reading all these and going, right-row, improper body mechanics? How can you guys help it? You're dealing with patients. You've got to lift, push, and pull things, right? Repetitive use, trauma, degenerative changes, which we all undergo. So just a little reminder to take care of yourself. Make sure you're lifting properly. Make sure you are stretching and strengthening as best as you can. So manifestations of a herniated intervertebral disc, it can be asymptomatic, but quite often this will manifest as sciatica, and the worse it gets, as a sidebar, okay, if you have a patient who had low back pain and sciatica, which is going to be the pain through the posterior buttocks down the back of the leg, and it starts to just go into the leg, it actually means that it's progressing and they're getting worse. If that pain in the leg goes away and it centralizes back to the low back, it means it's getting better. So that's just a little side note. This happened to me. I blew a huge disc, and I knew when it went just into my calf, it actually stopped hurting in my back, and it was just in my calf. And I had motor loss that, as much as I tried to stay out of surgery, I ended up in surgery. You could get pain, paresthesias, which is numbness or tingling, and weakness in the low back, in the leg, in the neck, in the shoulder, chest, or arm, depending on which plexus it's coming from. Is it coming from lumbosacral, or is it coming from the brachial plexus region? Or I should say the spine more specifically, cervical or lumbar spine. So let's take a quick picture, look at this picture of a herniated disc. So we're looking down on the spine. It's almost like I've cut myself in half and we're looking down. And this is the spinous process in the back, so this would be anterior. Here's a cut through the disc. And the annulus fibrosus is this outer portion, and the gel is a nucleus pulposus. And it's just like a really hard jelly donut. If we keep stressing it and we keep pushing on it, eventually we can push that jelly out and we can get a herniation. Unfortunately for us, biomechanically speaking, where these herniations like to go is right into our nerves that come out that provide innervation to either the arms or the legs. excuse me, you could also see how if it gets big enough, it can push back on the cord itself. And that's when we start to get more of those autonomic symptoms, such as loss of bowel and bladder control. Let's practice. What do you think this is? Just to get you oriented. I'm not going to give you too much. Here's the sacrum. Okay, so the patient would be pointing this way. What do you think these guys are, first of all? And what do you think these are? Practice all these things. While I'm going through it, it really helps you remember stuff. What do you think exists here? And what do you think this big arrow is pointing at? You're like, oh, I think I got it, right? Okay. I'm going to move the titles. So this is the spinal cord being compressed by the herniated disc. So let's quickly go through these structures. So this is going to be most likely an MRI, and it is going to be a lumbar MRI. And it's a mid-sagittal section or a sagittal section, and we're looking at the vertebra here, all these square structures, and between the vertebra are the discs. This disc is not only herniated into the spinal cord, I'll erase this so you can see it again, it's also desiccated, which means it's lost some of the water content in there, which means it's lost height, and it's lost, the nucleus pulposus has mostly snuck out the back there. Okay. And there you could see it. You could see that disc where the herniation is a lot darker. All right. So osteoporosis is very familiar, I'm sure, to all of us. And this is going to be a condition in which the amount of calcium phosphate actually okay, so what happens with osteoporosis is the actual constitution of the bone itself is okay. So if we took a little bitty bit of one person who had osteoporosis compared to somebody who didn't, the bone composition would be just about the same. The problem with osteoporosis is there isn't enough of it. So if you imagine that spongy bone in a healthy person, it would simply be a lot more dense than it is in somebody with osteoporosis. So there's a decrease in osteoblast activity. It's not going to deposit as much of the bone as we need. Or there's an increase in the osteoclast activity. Don't forget that happens in females as we lose estrogen. Osteoclast activity becomes increased. So that spongy bone becomes more porous, and the compact bone becomes thinner. So could be genetic, could be dietary, and we know all those. Could be hormonal, could be the loss of the estrogen that we spoke about previously. Also physical activity. Weight bearing, just walking every day, helps to create stress, especially in your femurs. That stress says, I need more calcium and bone here. It draws those precursors and then the calcium phosphates to it. It'll deposit more bone in that area. So lucky us, I got a double whammy here. I've got the advancing age and being female. So I'm really trying to be careful to ingest foods with calcium. Being underweight, not so much with me, but anyway, moving on. Osteoporosis, so we could get those pathological fractures. Quite often we'll see them in the spine in the form of those compression fractures, and also the hip. So bone density scans, I'm not doing a lot of diagnoses because there's so much else to cover, but I thought this one would be good to know just for your own edification. There is also a pathophysiological aspect to this that you should know. X-rays only begin to show bone density loss at 50% or greater. That's why patients have to go for the bone scans, especially at menopause and later, because you can't see it on X-rays until you've lost 50%, and then it's like too late. Okay, so once again, not doing a lot of diagnoses, but I think that one is important. And here's that increase in the kyphosis that we spoke about with the progression of osteoporosis. Now, rickets and osteomalacia are soft bones. So osteoporosis is the loss of the amount of bone. Rickets is soft bones. So what happens in both is that you get that cartilaginous precursor. Those collagen fibers are laid down, but they don't have enough calcium, phosphorus, or magnesium to put the calcium into the bones. So we get two forms. We get soft bones in both, but in children we get rickets. In adults we get osteomalacia. Now, the thing that happens that is different with them, oh, I thought I had a picture there. Give me just a second. I do have pictures in your Let's Practice. So we'll look at pictures of these in Let's Practice. Okay, so Paget's disease. Paget's disease is not something that you're going to often see, but this is a condition that causes excessive bone destruction, and it replaces that bone with fibrous tissue and abnormal thick bone. So even though the bone is getting bigger, it's not a normal bone consistency or composition. So it's actually fragile and weak. So you get these big bones, but they're fragile and weak. It's quite often in the long bones. You're really going to be able to see it in the skull. You could see it in the pelvis and the vertebra. And the way that it presents, if we move on to the next slide, is a cotton wool appearance. That's W-O-O-L, cotton wool. So if you look at this x-ray, and we're looking at normal on this side, okay, it has a gauzy kind of appearance, for lack of better words. Over here, you can see that cotton wool appearance. And what that means is it's like if you have cotton wool and you pull it apart, it gets that stringy appearance. And what they did with this patient is they sent them for a bone scan, and you can see this presentation of overactive bone on this side. But don't forget, even though it's overactive, it's not making the right type of bone. So this patient gets bones that are weak and fragile. All right, let's move on to a Let's Practice, and we're going to practice these bone formation disorders. So this is one compared to the other out of the ones we've just spoken about. And if you look at the left, this is a child, and if you look at the right, this is an adult. The one on the right is a little difficult to see. The one on the left is an infant with, what do you think? That is going to be, and what do you think the one on the right is? That is going to be the same disease in an adult. I think the picture on the right is a little difficult to see, but these are rickets versus osteomalacia. A rickets in an infant usually will present with a bow-legged appearance because the bones are soft, they start walking, the bones are developing, and they develop bow-legged because of the pressure they put through them, and they bow out. With osteomalacia, I have a better picture somewhere. This is hard to see. Usually you can see a slight bowing generally in the femur with osteomalacia, and quite often they'll see osteomalacia with a fracture, because even though the bones are taking some of the weight and they're starting to bow, sometimes it gets to be too much and you'll get a fracture in them, usually close to the femoral neck or the top of the femur. Next one. This one's a little tough. I'll give you a tip. We're looking at the edge of the skull. So with this, the condition, I'm just going to jump right into it because that one's a little tough, is actually Paget's. And when you look at their skull, I should have compared it to a normal one, you could see a thickening of the skull bone. That bone likes to thicken in Paget's. What do you think this is? Left is normal, right is abnormal. This would be osteoporosis. And of course, if you have to pause the tape, do so. But you can see the bone changes with osteoporosis. And once again, don't forget, the one on the right has to have at least 50% or more of bone loss. So you want to get your bone scans done and get those diagnoses early. Here is a picture of a patient. Once again, this is a repeat. What do you think this is? If you need to pause, go ahead and do so. This will be a young patient with rickets. So those soft bones with the bow-legged appearance, and you'll also have a decrease in the calcification, making it look like thinned bones. This is one compared to the other microscopically. This is going to be osteoporosis. Okay. A is normal bone. B, if you look at the surface of the bone itself, there's just not as much as there is in the top one. There's a lot more holes in it. There's a lot more spaces. So once again, with osteoporosis, if we were to look at just the cellular level, it's going to be just about the same as normal bone. There's going to be a lot less of it. This is one of the radiological findings of one of the previous diseases we've spoken about. This is going to be in the skull, and you have that patchy appearance on radiological findings. This is going to be Paget's with a cotton wool appearance. It doesn't have quite that spread out appearance like we saw with the pelvis, but that patchy white and dark is pretty pathognomonic or stereotypical of Paget's. I thought that was kind of a cool little x-ray for you. All right, I think we're going to pause the tape there, pick up in the next one, and that'll be our last one for musculoskeletal. Please let me know if you have any questions, as always, and I will see you in the next video. Thank you.